Welcome to the lecture orientation on nursing assessment and reassessment. I am Vivian Go from Nursing Quality Improvement Unit of the Department of Nursing Services, King Fahd Hospital of the University. This lecture aims to guide the staff on appropriate nursing assessment based on the data taken during physical examination and interview. Ensure that all patients have initial assessment and continuous reassessment based on identified needs. Refer to Policies on Patient Assessment, Nursing Assessment and Reassessment NUR 17-106 and Patient Assessment and Reassessment Administrative General 01055. Assessment is a key component of nursing practice, required for planning and provision of patient and family-centered care. Hospital 7th Edition Manual of Joint Commission International Standard Assessment of Patient, AOP goal is to determine the care, treatment, and services that will meet the patient's initial and continuing needs. An effective patient assessment process results in decisions about the patient's treatment needs for emergency, elective or planned care, even when the patient's condition changes. Patient's assessment is an ongoing, dynamic process that takes place in many inpatient and outpatient settings. Furthermore, patient assessment begins with initial assessment that involves obtaining baseline data, identifying diagnoses, develop a plan, implement the plan and assess patient's response and finally assess or evaluate the effectiveness of the plan of care rendered. What is nursing assessment? Nursing assessment is a systematic collection of data to determine the patient's health status and to identify any actual or potential health problems. Initiation of assessment will be age-specific electronically and/or manually during downtime. Sources of information is the patient, family, significant others, and other healthcare providers. One well-known author once said, nursing assessment should include client-perceived needs, health problem-related experiences, health practices, values and lifestyles. Bandman and Bandman 1995. In addition, he claimed that data obtained should be relevant to particular health problem. And in order to have a useful, relevant information, the nurse should think critically what to assess. There are two sources of information. Subjective information: the information obtained by the staff nurse by interviewing the patients, family and significant others documented in patient's own words that cover their emotions and perceptions. Also known as symptoms or covert data. Objective information: the information obtained by the staff nurse through physical examination, observation and/or diagnostic testing. It is signs or overt data, are detectable, can be measured and tested against a standard. These data are obtained utilizing the four methods of physical examination: inspection, palpation, percussion, and auscultation. When you communicate to take a data, be aware of the verbal and nonverbal way of communication. To gain trust and build rapport, you need to display genuineness or sincerity, respect or courtesy and empathy or understanding what he or she feels. To continue, reassessment: the act of assessing or evaluating again in order to follow the ongoing process of a patient's condition. Special population patients who fall under one of the following categories: children, vulnerable, end of life, patients with psychological needs, and adult patients on chemotherapy, patients are in need for isolation, patients with chronic pain, and pregnant women. Vulnerable patients: those patients who are unable to care for themselves due to their age, for example, children, elderly adults, altered mental and/or neurological status or abuse, and pregnant women in labor. For care of vulnerable patient, please refer to the Policy and Procedure Administrative General 01-022 for guidance. What is initial assessment? The first assessment or evaluation of patient. In addition, initial assessment will have its period on initiation and completion. The initiation of the initial assessment for regular wards will be within 30 minutes upon arrival and completed within the shift. For all critical units, within 5 minutes and completed within 4 hours. Labor and delivery, within 10 minutes and completed within 4 hours. Behavioral assessment: within 1 hour. The completion will be based on the cooperation of the patient. Nutritional assessment: within 24 hours by the dietitian. Medical history and physical: within 30 minutes and completed within 24 hours by the clinical team. And for the dialysis: within 30 minutes upon arrival to the unit. All initial assessment renewal is every 30 days from the time of admission. In King Fahd Hospital of the University, assessment can be done electronically in the Hospital Information System, HIS, or manually during downtime event. Refer to list of electronic counterparts for the paper-based nursing forms, in the KFHU intranet resources. You shall assess patient, family and/or significant other's learning needs and readiness. As teaching needs arise, a teaching plan shall be formulated and documented in the patient and family education screen or its paper-based counterpart during downtime. Refer to list of electronic counterparts for the paper-based nursing forms and multidisciplinary patient and family education policy, ADM Gen 01-052. See the example. Upon arrival of the patient to the unit, begin by introducing your name as his care provider. Welcome him by orientation to the physical setting, use of call bells, and give the brochure on patient's rights and responsibilities. For the next days of patient's journey, all instructions and teachings will be documented clearly and completely. Teachings will include new medications, use of some devices, and important instructions in relation to his treatment. Discharge planning. It is a process that involves the patient, their family, and healthcare professionals from various disciplines who work together to facilitate a smooth transition for the patient from one level of care to another, or to the patient's home, to ensure continuity of care. It is initiated at the time of admission and initial assessment and reassessed continuously throughout the patient's hospital stay. The patient, family, significant others shall be involved in this process as appropriate. Refer to the Policy on Multidisciplinary Inpatient Discharge and Discharge Planning, ADM Gen 01085. For electronic documentation of discharge planning, please see example. Emergency Department. All ER patients shall be triaged using visual triage checklist for acute respiratory illnesses, COVID-19, MERS-CoV KFHU. INF 12020, electronically or manually during downtime. For patient with score of 4 and above, instruct the patient to perform hand hygiene, wear surgical mask and direct the patient using the respiratory pathway and inform the physician for assessment. Triage acuity level classification as well as nursing triage assessment documented electronically through the Health Information System HIS. Or manually using nursing triage record NUR 17020 during downtime event. Patients with Category 1 and 2 to be taken to the crash area immediately and triage will be completed at bedside. Patients with Category 3 to be taken to the observation areas according to the age and sex, male, female, pediatric. Patients with Category 4 and 5 to be taken to the examination rooms for secondary assessment. Triage shall be conducted on the following areas. Male triage area, located in the area between the ER reception and pharmacy. Female triage area, located at the left side of ER reception. Pediatric triage area, located in front of pediatric ER. OB/GYN triage area, located inside of OB/GYN ER. Please refer to the Policy on Triaging and Management of Patient in Emergency Room ADM Gen 01-031 for guidance.
For ER patients that need further management, documentation in nursing observation assessment should be done electronically or manually during downtime. Based on the identified patient's medical needs, the emergency department's second triage nurse will accompany and hand over the patient to the specific area in emergency department for both clinical and nursing teams to perform further assessment and management. For overstaying patients in ER without admission order entry, an electronic nursing documentation shall be initiated for continuity of care utilizing SOAP format or manually during downtime event. See example, refer to list of electronic counterparts for the paper-based nursing forms, in the KFHU intranet resources. In the event that admission order was entered for overstaying patient in ER, and the patient needs to further stay due to unavoidable circumstances. Example, unavailability of bed in the inpatient unit, and other related reasons or issues, the appropriate electronic admission assessment should be initiated. Refer to the example, convert from emergency to inpatient, medical surgical admission assessment and transfer order. However, if the patient is still in ER on the following shift, the receiving ER staff nurse shall initiate the appropriate electronic shift assessment, which shall later be continued by the receiving inpatient staff nurse upon patient transfer. Delivery room. The delivery room nurse shall initiate the nursing initial labor record, KFHU NUR 17076, upon receiving a patient on labor from other units. The continuation of documentation shall be noted on the nursing labor record, KFHU. NUR 17030, once the nursing observation and intervention in the nursing initial labor record was completely utilized. Note: nursing progress notes shall be initiated using SOAP format. Still in DR. The nursing delivery and postpartum record, KFHU NUR 17035, shall be completed before transfer to the unit. If and when the patient stayed in DR more than the allowable recovery time, within 45 minutes to 1 hour, after delivery for any reason, example further management, or unavailability of bed, the delivery room nurse shall initiate the appropriate electronic or manual admission assessment and shift assessment for the next shift. Upon transfer to the regular OB/GYN unit, both the transferring and receiving staff nurses shall document the transfer on the appropriate form. Outpatient Department. The OPD nurse shall initiate the appropriate electronic clinic admission assessment and complete the minimal nursing assessment, which includes but not limited to vital signs, pain screening, fall screening, and assessment, general assessments such as functionality, behavioral, and patient family education. During downtime event, outpatient clinic treatment record form first visit, KFHU ADM 01016, referrals from other services or facilities. Outpatient clinic treatment record form follow-up visit, KFHU ADM 01020, follow-up appointments, will be utilized. For the nursing progress notes, the OPD staff nurse shall document using the multidisciplinary progress notes in SOAP format. The Hospital 7th edition JCI Manual Update on Fall Assessment stated: all ambulatory patients should be screened to identify who are at risk based on the fall screening criteria. However, the age-specific fall risk assessment shall be initiated if the patient is having a secondary diagnosis or with comorbidities, or is categorized as vulnerable, which is not limited to the following: geriatric patients, 60 years old and above; orthopedic patients; patients with disabilities, example, altered gait and balance, hearing and visually impaired; pediatric patients age 0 to 2 years old; hemodialysis and peritoneal dialysis patients; pregnant women. If any of the risk factors is noted to have one yes mark, the age-specific fall risk assessment shall be initiated, Morse Fall Scale for adult and Humpty Dumpty Fall Scale for children. Hemodialysis and peritoneal dialysis unit. All hemodialysis patients will be triaged using appropriate tool, KFHU NUR 17097 nursing triage record adult and pediatric dialysis. The hemodialysis triage nurse shall perform the following: take a brief history and initial temperature. Screen the patient for clinical signs and symptoms such as fever, cough, shortness of breath, sore throat, CRF, CAD, heart failure, and risk for COVID-19, MERS-CoV. In the event that the patient score is greater than 4, send to ER isolation room and inform physician on duty for further evaluation. Assess the patient for mental status, cardiac assessment, abdominal assessment, lower extremities, and vascular access if 5 or more check marks will be obtained. Then refer patient to nephrologist on duty. Upon arrival of patient in hemodialysis unit, the staff nurse shall perform assessments such as vital signs as baseline data, pre-treatment weight, and document his or her nurse's progress notes in SOAP format utilizing nursing hemodialysis treatment record KFHU NUR 17006. Receiving patient in hemodialysis unit. The concerned staff nurse shall initiate the nursing dialysis assessment form, KFHU NUR 17031, which is designed for series of dialysis treatment schedule. Note: if the outpatient hemodialysis patient is admitted, admission process shall be performed by the hemodialysis staff nurse and upon transferring the patient to the inpatient unit, the receiving staff nurse shall initiate the appropriate initial nursing assessment. However, if the patient overstayed more than the allowable time, the hemodialysis nurse will initiate initial nursing assessment. When receiving outpatients in peritoneal dialysis unit, who require simple procedures, which are completed within 2 hours, the outpatient clinic treatment record form follow-up visit, KFHU, ADM 01020, shall be used for minimal nursing assessment. Otherwise, for long procedures, which takes more than 2 hours to be completed, the nursing dialysis assessment form, KFHU-NUR 17031, shall be utilized. Upon patient admission to the unit, the staff nurse shall perform initial assessment of patient, vital signs, height, weight, pain completed within 30 minutes. Staff nurse shall perform a head-to-toe assessment for all patients reporting actual or potential physical health problems throughout their hospital stay. Information on the initial assessment shall be documented on the appropriate electronic admission assessment or to its paper-based counterpart during downtime, see example. Documenting vital signs electronically. Vital signs must be obtained on all patients in accordance with the routine of the unit or as specified by the physician. The attending physician must immediately be informed of any abnormal vital signs readings so that appropriate action will be rendered. The frequency of vital signs monitoring varies in the following unit. Critical, every 1 hour or per physician's order. Non-critical, routinely every 4 hours or based on patient's condition. Refer to Policy on Vital Signs KFHU-NUR 17-109. Pain is the fifth vital sign that refers to unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage, and which may occur independent of tissue damage. International Association for the Study of Pain IASP, 2009. There are two types of pain. Acute pain, pain of sudden onset that is often severe and of short duration associated with surgery, non-surgical interventions and some medical conditions, and is eliminated by treating the underlying cause in most situations. While chronic pain, pain that persists past normal healing time and hence lacks the acute warning function of physiological nociception. Usually pain is regarded as chronic when it lasts or recurs for more than 3 to 6 months. Pain screening, to elicit the patient's subjective account of their pain condition, that is, whether or not the patient has pain. An elicited yes answer to "Do you have pain?" leads to pain assessment. However, for patient who cannot verbalize if he or she is on pain, an age-specific pain scale shall be utilized. Refer to appropriate forms. You can locate this in KFHU intranet resources. To be guided accordingly, refer to Policy on Pain Assessment and Management ADM General 01-033. Pain screening shall be done within 30 minutes upon admission. Once a yes answer is elicited, pain assessment will be initiated electronically or manually using Pain Assessment and Reassessment KFHU-NUR 17039 during downtime. In the assessment of pain, the PQRST method of pain assessment is utilized. For pain score of 4 and above, pharmacological intervention should be implemented. The staff nurse shall refer to the attending physician for further assessment and evaluation. Note: the time of pain identification is different from the time of intervention. In short, all interventions should have its corresponding time as basis for reassessment. For post-intravenous and intramuscular intervention, reassessment will be within 15 to 30 minutes. Post-oral medication reassessment within 30 to 60 minutes, the same with non-pharmacological intervention. Fall risk assessment shall be done within the first 2 hours of admission utilizing age-specific fall risk assessment tool. Refer to Fall Risk Assessment and Intervention Policy. ADM Gen 01-038, Morse Fall for Adult and Humpty Dumpty for Children. Fall risk assessment and reassessment is based on the following: initial fall score, post-invasive procedure, upon transfer from one unit to another, change of condition. Post-administration of medication that place the patient at risk for falling, came in from out on pass, immediately after the fall incident and upon discharge. For fall risk assessment and reassessment, an age-specific fall risk assessment scale will be used either electronically or manually utilizing the following. For adult, Morse fall scale with levels of risk for reassessment: no risk 0 to 24, low risk 25 to 50 and high risk 51 and above. For children, Humpty Dumpty fall scale with levels for reassessment: low risk 7 to 11, high risk 12 and above. If and when a patient is identified as high risk to fall, a yellow ID band and a fall signage will be applied. All interventions done for prevention of falls documented in the multidisciplinary progress notes electronically or manually during downtime. Medications. All patient upon admission will asked on home medications and documented electronically or manually during downtime. The admitting nurse will interview the patient if he or she is taking medications prior to admission. If a no answer is elicited, the nurse will document electronically by clicking the box No Home Medication. Otherwise, if the patient is taking any medications and are in his or her possession, the nurse will document by clicking the box Document Home Medications and refer to the physician for reconciliation process, either to continue or discontinue the medications. Nutritional screening shall be done for all patients utilizing the standardized form. Refer to Scope of Clinical Nutrition Services Policy DIS 06-039. The admitting nurse will utilize an age-specific nutritional screening, see example. For a score of 4 and above, the staff nurse shall refer to the assigned clinical dietitian for further assessment. For patients in the critical units, the assigned clinical dietitian will conduct assessment electronically in the HIS, refer to the example. All patient will be inspected from head to toe upon admission. Any identified skin integrity impairment will be documented via the Hospital Information System or HIS. For skin risk screening and assessment, an age-specific standardized form will be utilized. For 5 years old and above, use Braden Scale Skin Risk Assessment. For below 5 years old but above 28 days old, modified Braden Scale Skin Risk Assessment Tool and Neonatal Skin Risk Assessment Scale for 0 to 28 days old. Reassessment of skin risk will be done as appropriate. Refer to Pressure Injury Assessment Prevention and Intervention Policy NUR 17-117 for guidance. Any hospital-acquired skin integrity impairment like pressure injury, the staff nurse shall document electronically or manually and report via Electronic Occurrence Variance Reporting System EOVR. Referral to the wound care team shall be done for further assessment and evaluation. For additional references and teaching guides, you can check through the hospital intranet resources. Utilize wound assessment for pressure injury or any significant wound upon admission using wound assessment record KFHUNUR 17038 or electronically viaduct the HIS. Reassessment of wounds will be done as follows. For mechanical wounds, or surgical wounds, reassessment will be done every dressing changed. Note: initial dressing shall be done by the clinical team. The succeeding dressing can be by the nurse or as ordered. For chronic wounds, example pressure injury, reassessment will be every 7 days or if there is change of wound status, either improvement or deterioration. Referral to the wound care team shall be done for further assessment and evaluation. To be guided accordingly, you can refer to the Policy on Wound Assessment and Management NUR 17-111. Do psychosocial assessment to identify patient's needs. Note: for identified psychological needs, refer to physician and complete the electronic psychiatric admission assessment or its counterpart during downtime. See example. For identified social needs, refer to social worker. Individualized age-appropriate plan of care shall be initiated based on patient's assessment identified needs. Document all identified problems as prioritized on the integrated care plan and problem-specific nursing care plan. Evaluate all identified, prioritized problems based on time frame. See example. Document appropriately as follows. Write the date and time when the problem is identified or upon initiation of initial assessment upon admission. Document the problem, crossed out the space of the goal, write on the column of Management Plan NCP for title of the problem-specific NCP. Crossed out space the following columns, time frame, outcome, and responsible, and finally in the last column, indicate your full name, designation, employee number, and signature. In the NCP, tick the box corresponding to the problem, either actual or potential, tick all the goals applicable to the problem, write the time frame based on your assessment. Tick all the boxes in the plan intervention as appropriate, document the date and time identified, then on the next column affix your initials and ID number. On the evaluation, if the problem is not resolved, write the word unresolved in red ink and affix your initials and employee number on the last column. Another time frame will be documented if unresolved based on your assessment, then the first and second column shall be crossed out. To be guided accordingly, refer to Policy on Nursing Care Planning NUR 17-115. For additional reference, refer to NCP problem list in the hospital intranet resources. Note: patient shall be referred to the concerned service according to the identified needs. For every current system status assessment, the supplementary form must be initiated or completed as required. The assessment for Glasgow Coma Scale, GCS, must be used for patient with neurological problems to check the conscious state. Document electronically or manually using the Head Injury Observation Chart, KFHUNUR 17-014, during downtime. See example. Functional needs shall be assessed upon admission. Any identified problems must be referred to the physician for proper referral to physiotherapy or neurology department. Assessment done shall be documented electronically by the identified interdisciplinary team. See example. Shift assessment. The staff nurses shall perform daily patient assessment and document findings in the appropriate electronic shift assessment form or to its paper-based counterpart during downtime. The daily physical assessment for inpatients shall include the review of system, pain screening, skin integrity, fall risk screening and assessment. Continuous reassessment must be done if there is a significant change in patient's condition, that is deterioration or improvement, treatment, or change in patient's diagnosis. Preoperatively and postoperatively, and transfer to another nursing unit. For postoperative patient who stayed in the recovery room more than the allowable time, of 2 hours, the recovery room nurse shall reassess patient and document appropriately. A complete reassessment shall be initiated each shift. Fall, pain, skin integrity, continuous reassessment on patient's functional needs, continuous psychosocial reassessment. Vital signs monitoring and document electronically or manually during downtime. Note: for continuity of care, patient transferred from the same level of services, example between regular units, the shift assessment initiated by the endorsing nurse can be continued by the receiving nurse. For different level of service, for example critical to regular unit or vice versa, the appropriate electronic shift assessment will be utilized or manually during downtime. For seclusion and restraints. All hospital staff shall be aware of hospital policy on the alternatives and the appropriate use of restraints within all patient care areas, and to ensure that the patient's rights are not violated when restraints are utilized. Restraints, a physical or medical devices used for restrict movement of the complete or part of patient's body to protect the patient or other from injury. In the policy on the use of restraints for adult and children, ADM Gen 01-077 states that all patients have the right to be free of restraints that are either not medically necessary or that are used for purposes other than for the patient's benefits and safety. Restraints shall be used only where alternative methods are not sufficient to protect patients or others from injury and are not a substitute for less restrictive forms of protective restraint. All patients will have an assessment performed to determine their needs for safety and protection, prior to the application of restraints or medical protective devices. Orders for the use of a restraint must never be written as a standing order or on an as-needed basis, PRN. Any order for restraint and the implementation of the restraint order must be in accordance with a written modification to the patient's plan of care, implemented in the least restrictive manner possible. Orders for restraint must specify the following: reason for the restraints, the type of restraint to be used and the extremity or body part to be restrained and the duration, time frame, for restraint application. Should a verbal order for restraints be obtained, the ordering physician must countersign this order as soon as possible and within 24 hours. Written orders for restraints are limited to 24 hours and restraint orders shall be rewritten at a maximum of every 24 hours and daily, after evaluation of the patient by the attending physician. The condition of a patient who is in restraints must continually be assessed, monitored, and re-evaluated and all details strictly and accurately documented. For the nursing team, assessment and reassessment shall be initiated by the staff nurse using the restraints monitoring record NUR 17048. All patients admitted to the hospital will have an individualized care plan after completing a comprehensive assessment by a qualified healthcare professional. The plan of care will be developed by the interdisciplinary healthcare team members, in consultation with the patient, family, or significant others, within 24 hours of admission. Planning process shall be individualized utilizing the data gathered from the initial assessment and from periodic reassessments. All care planning is an ongoing, dynamic process of integrating and coordinating patient care activities, planning and the delivery, across all settings, departments, and services through an interdisciplinary approach, directed towards the achievement of better patient outcomes. For long-term patients who stayed 30 days and above, all identified problems shall be documented in the individualized integrated care plan. Refer to the example. The staff nurse shall document all problems in the following manner. Write the date and time when the patient reached his or her 30 days stay in the hospital from admission date. Document all the problems, the goals, and the management plan applicable to the problem based on the assessment. Write the time frame on appropriate column. Note, time frame should be a minimum of 7 days depending on the problems based on assessment. On the column of outcome, leaving it blank for the date and time of evaluation, the column for responsible for another staff nurse to evaluate the problem. Finally, for the last column, the staff nurse who transferred the problems will affix her full name, designation, employee number, and signature. Note, any identified problems with short-term goal can be documented in this form. See example. To conclude, let me remind you of the following questions. What have you learned? What do you understand? How does it affect you as patient safety advocate? All these questions will guide you in your journey in KFHU. As it was said, assessment is thinking, assessment is feeling, assessment is doing. Assessment is accountability, not a liability, because it is responsibility for our practice as member of the healthcare team. Atkinson and Murray claimed that assessment is a part of each activity the nurse does for and with the patient. In short, the patient is fully involved in his total treatment, and he has the right to know, understand, suggest, and question for his betterment. Florence Nightingale, 1859, said, "The most practical lesson that can be given to a nurse is to teach them what to observe." Furthermore, she claimed, "For it may be said, not that the habit of ready and correct observation will by itself make us useful nurses, but that without it we shall be useless with all our devotion. This is written in her book Nursing What It Is and What It Is Not by F. Nightingale, page 160. To aid your understanding, the following references will guide you. You can locate these in KFHU Intranet. In addition to the list of references, the following can be located in the hospital intranet resources. As you begin your journey in King Fahd Hospital of the University, take this words from Linda Siski to inspire and remind you. All assessment is a perpetual work in progress. Thank you and more power.